are connected now for the meeting. Hello, everyone. Thank you for joining this first IWC Clinical Cases Symposium. We are very happy to be able to organize such a meeting with all the IWC centers. The principle is to involve our fellows, our current and former fellows of the IWC Center to share some interesting problematic clinical cases and discuss all together those cases. So, for example, today we have cases from Istanbul, Paris, Santiago, and Sao Paulo. Please feel free, especially for the youngest, to participate and to ask any question and to join the meeting. Please just switch off your microphone because it's today it's a meeting, it's not a webinar. Maybe for next time it will be a webinar. So for today, we have 5 cases to discuss. I think we will start. Benjamin Katir is ready and online, and we will start with his case. Benjamin is our current fellow here in Paris, and now he's a senior surgeon in Avicenne Hospital, and he has a case to propose and to share with us. Benjamin, up.
Hi everyone, thanks Alam for the introducing.
Perfect. You have it? Yes, we have it. You can start. Thank you, Benjamin.
Okay. So I'm here to speak to you about a patient I received. It's a post-traumatic radiocarpal arthrosis. It's a 47-year-old patient with right-handed, not smoker, manual worker, and he had a work accident on July 2021. He received an heavy load primarily on the left wrist. So here is the initial X-rays. So what can we see here?
Okay, we can ask maybe someone to comment this. Do you have an MRI or a CT scan, please, Benjamin? So we can ask our colleagues to comment.
No, for this patient, initially we had only X-rays.
Okay. So is there anyone who would like to comment those X-rays in that we had in the acute situation, please? Maybe one of our young colleagues. I can see Brahman is online. Brahman, please.
Yep. Yeah, so he's got a comminuted intra-articular distal radius fracture with a dorsal ulnar component and a radial styloid component.
Sorry, Brahman, I will interrupt you. To everyone, please, could you switch off your microphones because it's a meeting. We are not in a webinar. So if you don't talk, please switch off our microphones. Thank you so much. Brahman, you can go.
Yep, sorry. Yeah, so he's got a displaced comminuted intra-articular distal radius fracture with a styloid component and a dorsal ulnar component. In terms of his carpus, from these images, the carpus is subluxed dorsally, and it looks like his scapholunate ligament might be injured or widened. It's difficult to tell. That's all I can really tell from these images.
Okay, and for your therapeutic option in the acute situation, please?
Yeah, so I would do an arthroscopic assisted distal radius fixation for this through a volar approach.
Okay. So here we have indeed a styloid fracture associated with, hold on, a styloid fracture associated with probably SLT and posterior radiocarpal dislocation of the wrist associated with what it looks like, but we can be sure of it, bony tear of the dorsal radiocarpal ligament. So he has been operated. They did closed reduction and percutaneous synthesis by pinning, but we will back to this after. After 2 months, the X-ray after the pin removal. And I see him almost 1 year after the event, 1 year and a half. He's painful, still painful. He's painful on the quotidian activities, 7 out of 10. Increase in friction, extension, radial and ulnar deviation. Hold on. The Watson test is impossible, but is not painful on the radial steroid process and the proximal part of the scaphoid. It's not painful either on the insertion of the TFCC. He didn't return to work, no return to sport, and you can see, as you can see, he gained a lot of weight. Here is the mobility. He's stiff on the flexion extension, radial and ulnar deviation, but pronosupination is okay, and he has lost a lot of strength. So I did a CT scan. Here is the frontal and sagittal. So what's your conclusion about this patient? What would you have done differently, and what should we do now? What shall I do now?
Thank you, Benjamin. Please, could you go back to the imaging so we can comment the case? Yes, 1 or 2 picture you can move on. So please, is there anyone? I think we will ask a fellow first to comment. Maybe Brahman or someone else, if someone wants to comment the case.
May I speak? May I speak one thing just before?
Yes, of course.
First, congratulations, Alan, for organizing this wonderful webinar. It's not a webinar. It's wonderful
Maybe next
event.
one.
And I think it will be really interesting to discuss about what we should do before.
Yes, it's one of the questions.
It's the second question. I think it will be better to start with this question because it's very important to discuss about what we have to do. In fact.
Yes, because so I remind it to everyone,
and particularly when you have this kind of distal radius fracture, which is a complicated one. What is your the manner, the way to analyze the fracture? It's very important.
Of course, I think we can go on with because Brahman started with this. Brahman, could you please give your opinion, and after we will ask another
Sure.
person.
So my opinion on what I would do initially, or what is
yes,
initially.
Yeah, so initially I would have got a CT scan for this to further delineate the fracture characteristics. And as I mentioned, I would do an arthroscopic assisted distal radius fracture fixation. I would have gone through a volar approach and tried to anatomically reduce and fix the fractures using a volar plate. I would have also assessed for associated soft tissue injuries, and given that it looks like the scapholunate ligament is injured, I would have done a scapholunate repair using your technique, Prof. And then immobilized him for a period of 4 to 6 weeks in wrist extension.
Now, it's very interesting, Brahman, and I congratulate for this. But I was sure of your answer. You need a CT scan, of course, but you're a rich man in a rich country, and sometimes it's complicated to have this CT scan in emergency. So one thing you seem to forget, all of you, is the analysis of the X-ray after reduction in traction.
Yep.
And with that, you know, you perform a local regional anesthesia. You put the wrist on the plate and on the X-ray system in your OHA, and you pull on just to reduce with the ligament taxin. You can analyze almost perfectly the fracture, and it gives you in a very simple way. It gives you almost all information, and of course the CT scan is better. I agree with you, but it was just why I would like to discuss about that, because don't forget that with the second X-ray after reduction, you can have better information and you can choose the way to treat the patient without to have a complicated system with CT scan, etc. Because the CT scan, I think X-ray after reduction is better than CT scan without reduction.
And what about the arthroscopy? Is it mandatory for you in this case?
Of course, you can do what you want. But I just want to emphasize this point, that don't forget that the X-ray after reduction is very essential.
Absolutely.
And now for how to manage now, because it's a kind of a disaster we have. Is there anyone who, yes?
I mean, he's got post-traumatic radiocarpal arthritis and a slack wrist with mid-carpal arthritis, essentially. And so I don't think there's many reconstructive options left. And so I would be thinking salvage options. And for me, I would try and delay as long as possible, but I would be moving towards an arthrodesis, especially given he's a manual worker.
Yes.
I totally agree. Benjamin, you have already operated this patient or no?
No, I'm operating him next week. I don't remember.
Okay. Gustavo, hello, Gustavo Montovani. How are you doing? Thank you for joining. You want to discuss the case?
Yeah. Hello, everybody. It's a pleasure to be with you again.
Our pleasure.
Yes, I would like only to stress. Still in the discussion, the previous discussion is about the usual associated injuries in this case. So I have some similar patterns of this fracture, and mostly instead of the scapholonate injuries, is the extrinsic volar ligament usually is torn in those cases. So it's important to realize that eventually you have to repair the radioscaphal capitate or the long radiolunate ligament. And for that, the volar approach sometimes is useful, mostly not for the plate, but for the ligament repair. And the fixation, usually in the reduction and fixation, usually you need the dorsal approach, because the behavior is just like the reverse Barton fracture. So the fixation with the volar plate is possible, but is not maybe the best choice. Usually a dorsal small plate in the dorsal part, or screws in the dorsal part. But the volar approach, a small volar approach, used to be necessary to put some anchors in the distal lip of the radius to reattach small fragments and the attachments of the volar extrinsic ligaments. Just a comment for this before going to the complication. Thank you.
Thank you, Gustavo.
It's kind of the conclusion of my case, because I wanted mostly to discuss what we have to do today for radial axial fracture in new patients. So indeed, we need a CT scan to look for key fragments. And as you said, it might need specific synthesis. And in this case, also, you need to do an arthroscopy for look for associated lesions. And arthroscopy allowed us to assess and treat those lesions. Here we have a styloid fracture, and in this article, the literature say we have a lot of scapholonate tear associated in this case.
Thank you, Benjamin. So is there anyone else who would like to give his opinion about what to do now? Maybe Gustavo, what would you do now for this patient? What would be your optimal option?
Yeah, my first idea is a radioscapholonate fusion.
Because the mid-carpal joint seems looks not so
Okay,
bad.
yeah.
Yes. Okay,
Yeah.
not complete. Thank you.
But,
I saw Dr. Bouland also wanted to say something. Ismail Bouland.
I agree with
you, Dr. Bouland, we don't hear you. Sorry. Could you switch on your microphone?
we are in the same place. That's why I couldn't open my voice. That's why I speak in the Hanefi's computer. I think that in the first X-ray, I saw a scapholonate dissociation. Is it true? I want to see the first X-ray.
Benjamin, please. Could you?
In the first X-ray, it's obvious in the right side, the scapholonate dissociation is a pair, and in the first step, you have to do something for the scapholonate dissociation. That is the first problem, I think. But in the last position, my preference of the treatment is radioscapholonate fusion. It is the best option, I think.
Okay, thank you so much. If nobody else has
yes, I have another
yes.
option.
Yes,
in the current situation, I think I prefer to perform a first row carpectomy and interposition.
Yes, it would be capsular interposition.
Depending what I found, normally I use pronotor quadratus, which I detach from the radius or ulnarly, depending on the local condition. But in my experience, it's very better than the partial fusion.
Because because he's a heavy worker and he's 47. That's what that is what.
Yes, it's not a problem at all. If not, it's a complete arthrodesis. But
okay, thank you so much for this nice case. So we have the choice between those two therapeutic options. Please, everyone, could you switch off your microphones? So now we will move to the case from Istanbul. Dr. Hanifa Shusho has prepared a very nice video. Benjamin, could you tu peux départager ton écran? Very nice video for Kiembrock case with the surgical technique. So I will try to play the video. Please stop me if the video is not, the quality of the video is not good. So here we go. Sorry, just a moment. I have to.
Hello and a very good afternoon. I'm Hanifah Yusuf from Malaysia. First, I would like to thank Prof. Dr. Ismail Bulen for accepting me as a visiting fellow at Istanbul International Research Center. For the past 3 weeks in this center, I think I have learned a lot. I can join the clinic, work round, and other educational activities. Most importantly, I got one-to-one training as a first assistant during operations performed by Prof. Bulen for up to 3 to 6 cases daily. I have seen a lot of hand and wrist cases. I learned many new things, especially those related to wrist arthroscopy. Today, I would like to share my experience in this center in managing case of Kimbok disease in stage 3B and 3C Leishman classification by performing arthroscopically assisted mini open proximal row capectomy, AAPRC. A 30-year-old gentleman presented to us with long-standing, progressively worsening pain and swelling over his left wrist associated with reduced wrist function and weakness. On examination, the left wrist range of motion is limited, especially on flexion and extension arch. Apart from that, there is swelling and tenderness around the left wrist region, especially over the dorsal aspect of the wrist with limitations of the left wrist passive range of motion. X-ray radiographs show sclerosis and collapse of the lunate bone with no obvious osteoarthritic changes over the radiocarpal and mid-carpal joint. CT scan shows the lunate bone collapsed and fragmented with capitate have migrated proximally with the scaphoid in the hyperflex position. These CT scan findings correspond to Leishman stage 3C. This T2 weighted MRI image shows increased signal intensity over the lunate bone. Regarding surgical techniques, AAPRC was performed under regional anesthesia and a pneumatic arm tourniquet. Firstly, we use the standard 3-4 portal for viewing portal to visualize the radiocarpal joint, and then 6R portal for working portal. After visualization of the radiocarpal joint, we usually perform arthroscopic debridement and synovectomy to relieve pain and mechanical symptoms. Following synovectomy, we can see all structures in the radiocarpal and mid-carpal joints easily. After that, we examine the proximal part of the lunate surface. Hello and a very good afternoon. I'm Hanifah Yusuf from Malaysia. First, I would like to thank Prof. Dr. Ismail Bulen for accepting me as a visiting fellow at Istanbul International Research Center. For the past 3 weeks in this center, I think I have learned a lot. I can join the clinic, work round, and other educational activities. Most importantly, I got one-to-one training as a first assistant during operations performed by Prof. Bulen for up to 3 to 6 cases daily. I have seen a lot of hand and wrist cases. I learned many new things, especially those related to wrist arthroscopy. Today, I would like to share my experience in this center in managing case of Kimbok disease in stage 3B and 3C Leishman classification by performing arthroscopically assisted mini open proximal row capectomy, AAPRC. A 30-year-old gentleman presented to us with long-standing, progressively worsening pain and swelling over his left wrist associated with reduced wrist function and weakness. On examination, the left wrist range of motion is limited, especially on flexion and extension arch. Apart from that, there is swelling and tenderness around the left wrist region, especially over the dorsal aspect of the wrist with limitations of the left wrist passive range of motion. X-ray radiographs show sclerosis and collapse of the lunate bone with no obvious osteoarthritic changes over the radiocarpal and mid-carpal joint.
HDMI2
CT
நம்ம
scan
HDMI1
shows the
திருப்பி
lunate
input
bone
கட்டுமா இப்படி
collapse
வரும்
and fragmented
இப்போ மேலே
with
போயிட்டு
capitate have
வந்துட்டு
migrated
HDMI
proximally with the scaphoid in the hyperflat position. These CT scan findings correspond to Richmond stage 3C. This T2 weighted MRI image shows increased signal intensity over the lunate bone. Regarding surgical techniques, AAPLC were performed under regional anesthesia and a pneumatic arm tourniquet. Firstly, we use the standard 3-4 portal for viewing portal to visualize the radiocouple joint, and then 6R portal for working portal. After visualization of the radiocouple joint, we usually perform arthroscopic debridement and synovectomy to relieve pain and mechanical symptoms. Following synovectomy, we can see all structures in the radiocouple and midcouple joints easily. After that, we examine the proximal part of the lunate surface. Then, we enter the midcouple ulnar portal as a viewing portal to evaluate the midcouple area. We start looking for lunate fractures first at the distal part of the lunate in the midcouple joint. Again, we usually perform synovectomy and debride the bone to see the fracture site clearly. Most of the time, the fracture site is over the middle part of the lunate, making it non-salvageable. We are performing synovectomy using midcouple radial portal as a working portal. We see and control the fracture line with arthroscopic and fluoroscopic aid. After that, we change our viewing portal to the midcouple radial portal and try to remove bones at the ulnar side by using midcouple ulnar portal as a working portal. We keep all the ligamentous areas at the ulnar side, like the ulnar thoracic and ulnar lunate ligament, intact. The thoracic, lunate, and proximal pole of the scaphoid were excised. From the midcouple radial viewing portal, we check the hamate and lunate articular surface and try to remove all the remnants of the bone part of the thoracic and lunate. We try to save the articular surface of the hamate and pisiform at the radiocouple area. We do not remove pisiform and keep it intact. And then we change our viewing portal to the midcouple ulnar portal and start to remove the lunate bone and its remnant through arthroscopy. During the removal of the proximal carpal row, care is being taken to protect the articular cartilage of the head of the capitate and the lunate fossa and all the surrounding ligamentous structure. During our early experience performing this procedure, we used an arthroscopic burr. However, we found using burr is difficult to control and take longer duration. Currently, we like to use curettage as we found it is easy to control and faster. The fluoroscopic view was obtained after the arthroscopic part of the procedure ended. The distal part of the scaphoid remains. We found it difficult to remove the distal pole of the scaphoid through arthroscopy. After that, we start mini open surgery to clear some remnants in the ulnar side and distal pole of the scaphoid. The mini incision starts 1 cm radial to the 3-4 portal. We can safely enter the radiocouple joint without causing any damage to the radiocouple ligaments, as the incision area over the dorsal-radial aspect of the radiocarpal joint is away from any ligamentous structure area, and it is empty space in this area, as shown in the red circle of this picture. After the skin incision, we identify and protect the superficial radial nerve. In addition, extensor pollicis longus and extensor pollicis brevis were retracted and protected. After exposing the radiocarpal capsule, we just make a short incision over the dorsal radial aspect of the radiocarpal capsule, which has no any ligamentous structure as mentioned before. Later, remnants of the bones over the ulnar side and distal pole of the scaphoid were removed from this mini open area. This is the head of capitate bone after remnants of bones and distal pole of scaphoid had been removed. The final fluoroscopic view was obtained after the mini open part of the procedure ended for the complete removal of the proximal carpal row. Traction is then released to confirm the seating of the head of the capitate in the lunate fossa. Then, after closing the capsule and skin, the thick bandage was applied to provide semi-rigid support. This video shows our patient on day 3 post-operation. On day 3 post-operation, we asked the family members to do physiotherapy for the patient. We call this approach family-assisted physiotherapy. This is the result at 3 months post-operation, one of our patients. This is another patient at 14 months post-arthroscopic proximal row capectomy, showing nearly normal wrist range of motion. This is our recent publication in AHSS Journal, which was published last year, 2022, comparison of clinical outcomes in open and arthroscopically assisted mini-open proximal row capectomy for Leishman stage 3B and 3C Kimball disease. Our recent study comparing open versus arthroscopically assisted mini-open proximal row capectomy in Leishman stage 3B and 3C demonstrates better results concerning early VAS, Q- and Mayo risk scores than open PRC. In addition, risk selection was also better in the early and final follow-up for the AA-PRC group. The better outcome in the AA-PRC group was probably because this surgical technique can start wrist movement immediately after surgery, and most importantly, the dorsal capsule and ligaments were not damaged. In conclusion, arthroscopically assisted mini-open proximal row capectomy, a good surgical technique that allows early post-operative wrist motion, resulting in increased range of motion with good long-term outcome.
Any questions from the floor?
Thank you, Hanifa and Dr. Boulen for this very nice video and the nice technique.
Any questions from all of you?
I don't have a question, but I just would like to congratulate you. And you know that the next FESH in Rimini will organize with Andrea Tsai a special session called hybrid session, arthroscopic hybrid session. And I think it will be really interesting if you can present this technique, because it's a new technique, and the hybrid technique is a new way between open and arthroscopic technique, and it seems very interesting. How many cases do you have operated like that, and what is your follow-up?
Let Bulan want to answer.
Hello, Christophe. How are you?
Hello, Bulan. How are you?
Nice to see you again, and thank you for your good comments. I performed this technique for 10 years, and it is when I realized that the arthroscopic way has got much more better results than the open techniques. It takes in the first step a very long time, but after that, we have got a lot of new tricks for to excise the bone, and it is about 2 hours. It takes about 2 hours, but the day after the operation, we started physiotherapy and allow the patients to daily activities. And people use their hand the day after operation, and it is easy for the patients for the daily activities. And after 2 weeks or after 3 weeks, they could do their ordinary works and ordinary jobs. And I am very happy about the results. And we have over 50 cases in our clinic. And more than 50, I don't know the real number. In 2 weeks, we did
Application 20.
We did 2 more with Hanifa, and he showed he saw our results, and we discussed a lot about this technique. That's why I want to share our experience in this kind of operation.
Will you plan to attend the FESH meeting or not?
I am not sure. We will.
Okay.
We will.
Dr. Boulant, if you attend, because we will have a similar presentation in the, yes, we will move on in the next IRCAD. So maybe we will share. You will share your experience with us about pre-book.
If I am sharing in this Congress, I will be glad. Thank you for kind invitation.
Thank you.
Thank you for your kind invitation for this meeting, and I am very happy to be in here with you, and I hope you will continue these activities. Thank you.
Thank you so much. So now I think we will move to the, thank you so much for Istanbul. I think we will move to the case of Brahman, who is our current fellow here in IWC Paris. He will talk about 2 cases of scaphoid proximal pole destruction. And we will discuss this case now. Brahman, could you share your screen, please?
Can you hear me?
Yes, perfectly. Thank you.
2 seconds. And can everyone see me?
Yes, we can see you and hear you. It's perfect.
Fantastic. Thanks, everyone. My name is Brahman, and I'm currently in Paris. I just wanted to thank the unit. Hello?
Yes, we can hear you, Brahman. No worries.
Sorry, it's just something coming up from Zoom. I just want to thank the unit and thank Dr. Anawid for organizing this. I'm presenting 2 cases.
I think.
So I'm just going to be talking about 2 cases of proximal pole scaphoid destruction, and I'll keep it fairly brief and then we can open it up for discussion. So the first patient is a 27-year-old right-handed commercial worker who had an injury 7 years ago with the proximal pole scaphoid fracture and had open fixation through a dorsal approach, as you can see here. This was his x-rays at 5 months. He was treated at another centre, and then he was lost to follow-up, and he presented to Dr. Arnaud's rooms 7 years down the track. So now, does anyone want to comment on these?
Shall we ask one of our colleagues? I can see just here Dr. Javier Sanchez. Sava, would you like to comment, please?
Hello. I
Hello.
think there is a proximal migration of the screw, and the scaffold force is damaged. I don't think maybe a DC in the first photograph is showing too. I think it's going to have some arthritic change.
So this is the 5 months post-op X-ray.
Okay, there are several arthrosis of the scaffold.
We can see 5 months after the first surgery 7 years ago, the non-union and the migration, the screw starts to migrate proximally. You can show the other X-rays, Raman, please.
Yeah, and these are the current X-rays. And so the major problem now, so as you said, there's proximal row migration, proximal screw migration. There's a non-union of the fracture, and the screw is abutting the radius with destruction of the radius. His major complaint is pain. The patient actually has a reasonable range of motion with normal pronation and supination, but slightly decreased in all other parameters, and has reasonable grip strength too, symmetrical to the other side. This is the MRI that was performed.
So I think we can stop a moment now. We can stop a moment now to ask if anyone wants to give his opinion. I can see there is Abhijit, Lorenzo, Francesca. Anyone wants to comment the imaging, please? Hello, hello. Francesca.
Hi, everybody.
Hello, Francesca. Francesca,
hi.
Could you? Hi, hello. How are you doing?
Hi, very good. So me, I'm also currently in Paris, and so clearly we need to perform a screw removal, and then I think the proximal pole of the scaphoid is not viable. And so either it's to be removed and we can do some type of interposition.
Which interposition, sorry?
I would do tendinous interposition.
Okay. Tendinous interposition with a pin removal. Now, okay.
Because I think what's causing the pain is basically the hole he has in the radius caused by the screw.
Okay, so you let the whole scaphoid and you remove only the proximal pole for you, Francesca.
I think the proximal pole is non-viable. If not, you can even if not try and do a vascularized graft. But that I think it means then a lot of period of immobilization, another screw.
But what about
to fix that?
Yes, but what about there is some radical arthritis, especially on the radius or the scaphoid fossa. I see Abhijit wants to talk. Abhijit, please.
Hi, Alam. Bonsoir.
Hi.
Hello, everyone. This is an exciting and a wonderful initiative, Alam. Congratulations.
Thank you.
I think so. His current problem is that of pain. His function is fantastic, despite the very scary looking X-ray that we see. And
that is the
obviously,
problem. Yes.
yeah, so the X-ray and the MRI pretty much show that there is a snack wrist, I would say perhaps a snack one wrist. And there looks to be some nice fibrous non-union. I would perhaps just think of removing the screw, maybe do a posterior intraosseous nerve neurectomy, and then do a radial stylectomy arthroscopic and leave it at that, which in my humble opinion would address the pain that he is having while maintaining the fantastic function that he has. Should the function worsen over a period of time, I think at that point in time, you could have options like scaphoid excision and a four-corner fusion or some salvage procedure. But I do not want to burn any bridges behind me at this point in time and just address the pain that he has. Just my 2 cents of thought. Thank you.
Thank you, Abhijit. The problem here is we have some changes, degenerative changes, and a huge geode on the radial metaphysis. What do you think about this? Can
So
we just perform here?
I think the arthroscopy will give us a very good idea as to what is happening. And if we do a radial styloidectomy, I think that should perhaps be sufficient. It will give you a good idea about the cartilage in the scaphoid fossa, and maybe just buy some time. If at all the cartilage is compromised, you could still then think of doing a scaphoid excision and a four-corner fusion, perhaps.
Okay, so we stay conservative and we look what happened after. Is there anyone else who would like to comment, to give his opinion, his or her opinion? I can see there is here Lorenzo is online. We have Lorenzo. No.
Yeah. Yes, I'm here.
Hello, Lorenzo.
Hi. How are you? I think I would have to say almost the same thing as Abhijit just say. I would stay the most conservative as I could at this time, and only see with time if I have a worsening of the situation. But probably if I have some good functional results with the screw removal and perhaps maybe a small debridement of the joint with arthroscopic mini-invasive cleaning of the joint, it would be efficient as a first step, actually, and do only a salvage or a palliative procedure such as a four-bone fusion or a PRC maybe afterwards only.
Thank you, Lorenzo. So for everyone, for the moment, conservative treatment, conservative option. Brahman, could you go on the case, please?
Absolutely. So these are the other MRI scans, and you can see the big geode that Dr. Anawat was talking about. And this is a video further describing that.
You can see there is a huge shield.
Yeah. And so we discussed the preferred therapeutic option, and I think that's where Dr. Anawat ended up. So took the screw out, and this is where we're at.
So yes, I just removed the screw. For 6 months, the patient was much better for the pain. And now there is a recurrence of the pain. He has, as Brahman showed you, almost all his range of motion. And I will have to make a decision soon about this patient who is not a heavy worker and whose complaint is mainly the pain. So if someone can comment now on the secondary therapeutic option for these patients, please. I was I don't know if Christophe is online, because I wanted to, I had a question, especially for Christophe or anyone else. If removing the proximal pole and putting an implant here could be a good option. I don't know if someone has an opinion on this.
Yes, you could eventually maybe do some kind of
Yes.
APSI replacement of the proximal pole, but you will still have to manage because it's hard to tell if the pain is actually due to the radiocarpal degenerative change or to the scaphoid aspect of the maybe fibrous non-union or something. So APSI is kind of a risky procedure in that case, because it won't allow you to have maybe a good result on the radioscaphoid arthritis.
Yes.
Or maybe you can combine it with the tenderness interpolation, maybe.
Yes, that was my question, because we don't have any experience in combining interposition and putting an implant, or putting an implant for proximal pole replacement when there is radiocarpal changes. So I see Abhijit has Abhijit wants to talk.
Alan, so I agree with what Lorenzo is saying. This is a challenge to know where exactly the pain is coming from. Is it radiocarpal arthritis, or is it the styloid and the scaphoid? So my question to all of you is that, is there any role for the MR cartogram, as we call, wherein you map the cartilage and you find out what exactly is the reason or the location or the origin of pain from? I would feel that an arthroscopy would give you that answer, no doubt about it. But in a lot of cases, we find that the radiocarpals, the radial styloid and the scaphoid is the culprit, and perhaps doing a styloidectomy combined with denervation would perhaps still give you adequate time in terms of delaying a salvage procedure. So just something that I want to know from Lorenzo and all of you.
Actually, when we precisely do the clinical examination for this patient, we have the pain which is really precisely on the metaphyse in front of the proximal pole of the scaphoid, where there is a geode, in the location of the geode. So we assume the pain is mainly, the main reason for the pain is this degenerative changes in front of this geode. So, but, thank you for your opinion, Abhijit. I totally agree.
Thank you.
So if nobody else wants to talk about this,
I think,
Brahman,
Alam,
yes.
There is a question from Ita Ramirez. So she is asking if osteonecrosis always does not correlate with the MRI, which is true. And would anyone think, can you just address those questions that she's asking, please?
Okay, does anyone assess the viability on the only basing our findings on the MRI? You can, please. Yes, I think for me, I think the arthroscopy would be the first step, really to confirm and to assess the viability of the proximal pole. And even if we move to a proximal pole replacement, the first step we do it under arthroscopy, and the first step would be the confirmation of the viability under arthroscopy. I don't know if I answered the question. Where is that? Okay. So Brahman, could you? We have another case of proximal pole destruction.
Yeah, in the interest of time, I might try and move through this pretty quickly because we have a little discussion at the end too. And I wanted to get the opinion of all the senior surgeons here. So I'll just move on. And so our second case is another case of Dr. Arnaud. It's a 19-year-old right-handed medical student who is also a high-level handball player and had a quite proximal pole fracture, which was fixed through an open dorsal approach 3 years ago at another centre again, and has presented to see her with these initial x-rays. And so you can see on the x-rays that the screw looks like it is backed out proximally. And her major issues at this stage, or his major issues at this stage, are pain, very severe, as well as decreased grip strength, but his range of motion, again, is intact. And on the MRIs, you can see decreased signal on the T1 weighted images on the proximal pole, and the scaphoid, so the lunate is quite extended. Sorry, someone's not muted. And so again, the CT scans and the clinical image. And so we're going to discuss the optimal therapeutic option. Alam, are you happy for me to just go through the list?
Yes, please.
Yep. And so I guess what we were thinking is that in terms of the ideal management for this, we would ideally try to, if everyone can just mute their.
Brahman, just a moment. Dr. Ali, can you please mute yourself? Or Alam, you could do that. You are the
yes,
the
but I'm trying to find who is not.
It's Ali Saljut.
Okay.
Ali.
Perfect. Thank you.
Thank you very much. And so in terms of long-term management, whatever we do, we want to try and avoid the long-term complications from this. And that includes radiocarpal osteoarthritis, carpal collapse, and secondary scapholunate instability. And the considerations that we have whenever we do anything for such a difficult problem is the actual articulating surface, so the cartilage reconstruction, and then the ligaments, in particular scapholunate. And so looking at the literature, there's 4 main treatment options. There's the free tissue transfers, I guess. So the medial femoral trochlea, which is vascularized. You can do non-vascularized osteochondral grafts, either from the proximal hamate or from the rib. And then, as we've already mentioned, a synthetic implant, such as the APSI, any sort of pyrocarbon implant. And each of these has its benefits and drawbacks. So with the medial femoral trochlea, the benefit is that you're replacing it with like for like, so cartilage, with its independent blood supply, but there is a significant donor site morbidity. I think about 30% of patients have ongoing knee problems, 10% have long-term knee pain, which is moderate, with 20% having mild knee pain. And it is technically challenging, a long operation, which requires microsurgery. The proximal hamate graft, again, is a non-vascularized reconstruction, which replaces cartilage with cartilage. But we have good, I think, short to medium term outcomes, but we're not really sure what happens in the long term on carpal biomechanics. And again, it's difficult for ligament reconstruction. Similarly, the rib osteochondral graft replaces cartilage with cartilage, but it is not vascularized. It's basically acting as a biological spacer. And there is risks associated with harvesting a rib, including pneumothorax. And then the last thing that is an option would be a synthetic replacement, such as a pyrocarbon implant. And so I just wanted to open the floor to all the experts here and see what each person preferred in this situation and what their rationale was.
Thank you, Brahman. If someone wants to give her opinion on this situation, a very young patient with the destruction of proximal pole destruction, and Brahman showed us all these concerns about each main therapeutic option. I see maybe Abhijit, Gustavo, or Shudenrin. Shungze, are you here with us? Would you like to speak? I can see you're here. Hi,
Oh,
how are you
hello.
doing?
I'm good. Good. Thanks for having me. Actually, I'm
Thank
Z
you for
from
joining.
Singapore. Well, I think this is quite a difficult case. It's a case of a proximal pole scaphoid fracture that was fixed and sort of became not united, and the screw sort of migrated proximally, pretty similar to the case before this. And I think the issue is whether there's arthritis or not. I think in this case, there isn't any arthritis. So now what do we do with this kind of fractures that are quite difficult to fix? I would look at the real estate of the proximal pole. You know, I would probably, definitely it needs to be refixed. So I would remove the screw and I'll look at the real estate of the proximal pole to see whether can we refix it again. This
Actually,
time with
sorry, I'm going to interrupt you. Actually, the screw was removed and the proximal pole was completely destructed. Not
completely
reconstructible.
right?
Yes, not
Okay, so
reconstructible in this case.
it's not salvageable. Okay, so if it's not salvageable, then you know the options are here. But I don't really have experience in all these other like APSI and so on. But I would say that a medial femoral condyle would be an option. But of course, you know it's technically challenging and so on. But I think another option is obviously the proximal hamate graft, which both I have no experience in. But I did see a proximal hamate graft that was done, you know, by a different surgeon, and there was a recurrence of non-union, and this time the proximal hamate is not there. So when we want to do and then there's an issue of like salvage option, and then when you want to do a proximal, if you want to do a four corner fusion, there isn't any enough. There's a space at the proximal part of the hamate. So yeah. So that's that. Yeah.
Thank you for your opinion. I can see like Dr. Bulent wants to talk. Please, Dr. Bulent.
The medial femoral condyle flap is suitable for this kind of proximal site of scaphoid defect. I think that medial femoral condyle is good options and good solution for this kind of problem, and it is easy and it is not takes too long. Believe me, the medial femoral condyle flap is very easy to take it, and the genicular artery is very clear at that area, and you can take the condylar surface easily, and with some experience it is not hard to do, believe me, and it fits like a proximal scaphoid. And the union rate is very high because of because of the vascularity of the bone, and the problem is to gain the range of motion. It is not easy to gain it again, and the patient has got problem about the restriction of the motion. Thank you.
Thank you, Dr. Bulent. That was the problem. We didn't choose this option of medial condyle graft because of the problem of the stiffness. And the second issue is we're afraid about the donor sites that are described in the literature and that are quite frequent in those cases.
It is not affect the donor site because the and condylar graft on the safe zone. You take the cartilage on the safe zone. That's why you haven't got any adverse effect in that area. It is not affect.
I think there was a systematic review that was done last year, and this is just what I've read, but they reported 50% saphenous nerve dysfunction, and then 30% of all patients had some pain in their knee. Is that your experience too, Dr. Ballant, or is that not what you see?
In 3 months, they have some pain. Yes, you are right. But after 3 months, the patient hasn't got any problem with about the knee. They can walk on it the day after operation, and you haven't got any restriction after the operation. It is not in the it is not affected the patellar way, and it is a safe zone, and everybody use this cartilage in the knee condylar defect, and they haven't got any problem also. Why you afraid of this kind of problem? It's not affected in the cartilage in the weight bearing area or patellar way.
Okay.
So we need to visit Dr. Ballant in Istanbul, Brahman. I think to improve our technique. Thank you, Dr. Ballant. So, Brahman, could you conclude, please, the case because we need to move to the next one.
And so, yeah, this is what we did. Excised the proximal pole and an APSI. Yep.
Yes, so we talked about this case before the surgery, and it appeared that the less worse therapeutic option for us, even if the patient is 19, is the APSI under arthroscopy, because we have no experience rib, and we have some concern with the rib osteochondrografts. The patient has had all his range of motion. And now, Rahman, could you conclude, please?
Yeah. So follow-up at 1.5 years, no pain, and has returned to normal sport. So he's done quite well. So I just want to say thank you, everyone, for being here, and thanks again to the people in Paris. Really appreciate it.
Thank you, Brahman. We were very happy to have you for this 2.5 months. Is there anyone who would like to make a comment about this case, please?
Alam,
No?
may I?
Yes, of
Alam,
course. Yes, please.
Yeah, very quickly. So I think it was a great case for discussion, wherein all the options that were very nicely discussed. I think all of us need to bear in mind that reoperation for a scaphoid that has been operated, and again, there is a non-union, especially more so with the proximal pole, is a great challenge. And most of the reoperation procedures wherein you are attempting to gain union would have a very high chance of failure. So not only, there's a very, very nice paper that I would urge everyone to read if you haven't, by David Ring, I think in 2015 in the Journal of Hand Surgery, and another friend of mine from Iran, Amir Kachui, they published a paper wherein they looked at different factors that are associated with reoperation for scaphoid non-union. And the APSI, I think, is a very good choice. Well done. And for people who do not have an access to APSI, I think a salvage procedure would make sense rather than trying to do these vascularized bone grafts, non-vascularized bone grafts. Because remember that most of the procedures or the successes that have been described in literature are anecdotal. There is no compelling evidence to prove the superiority of these procedures over salvage. So thank you so much.
I totally agree. Thank you, Abhijit. I think we need to move to Gustavo case right now because he has an appointment. Gustavo, do you think you have enough time to share your case?
Yeah, I can stay for 20 minutes, but
and you can
okay. Okay, so thank you. I just want to share to add a little bit of discussion in this wrist session. This interesting case that I operated 2 weeks ago. So it's old guy, 65 years old male with his right dominant hand and presenting with this X-ray and this MRI. Come back a little bit just to propose a discussion. I don't have further examines more than this. This guy do not remember the original injury. He just become to have pain in the wrist and the lack of ability to function in the last 6 months, about the last 6 months. He used to have a light pain in the wrist in a couple of years, but become disabled in the last 6 months. So that's the presentation. I put this in discussion because to discuss a little bit the alternatives of techniques for perform the salvage procedures for this kind of arthritic wrist. I would like to hear any opinions from the friends.
Yeah, I think we will ask the young friends to is anyone interested in commenting, please?
One question I would like to hear about is the opinions is about this atypical presentation of the styloid, of the radio styloid. So how do you see this? How do you interpret it?
Dr. Jorquera, please, René, we would like to hear from you, your opinion.
Yes. Hi,
How are
hi
you?
everybody. Hi, Gustavo. I have a two questions. Yeah, my friends. I have a two questions. You don't know what is the initial injury? What is the state, the surface of the mid-carpal and radiocarpal joint? You know, you don't have another CT scan or MRI?
No, I have the other slices of this MRI, of course. I can say you that I'm pretty convinced that the mid-carpal joint is not viable. The proximal pole had several images of subchondral cysts, and the X-ray, if you can see the space and mid-carpal space, it's already compromised. So my opinion is it's a compromised mid-carpal joint.
I see the compromise of the radioscaphoid joint and mid-carpal joints and the proximal pole of the capitate. It's very important. We don't have the compromise of the mid-carpal joint. We have several options or treatment options, and in this case we don't have that several options, and we have only two options. That is for cornea fusion and scaphoidectomy, and for cornea fusion or total wrist fusion, and depend of what is the activity of the worker or sports. What is your opinion? I think that the only option when the radiolate.
Yeah, I think there is no much discussion about the option of the four corner fusion. The PCR in this case is, I think, is not a good option because of the capitate compromise. The curious thing for me in this was this big fragment on the styloid. I figure out what happened there. If this is osteophyte that probably break at some point and evolved with a kind of non-union of this fragment, or if this was originally a styloid fracture that compromised the scaphoid ligament, and that's a curiosity on this case. But for corner fusion, I completely agree. I think it's the best option. And I bring this case, in fact, most to discuss, and you are the right guy to the discussion, is about the choices of techniques, because in the last at least 5 years, I do all my four corner fusion arthroscopically, but this was an exception for me. So I would like to hear how do you approach this case in the operating room?
the first option is arthroscopic for corneal fusion. We do in this moment a complete diagnosis of the state of the surface and the mid-carpal and radiocarpal, and what is the compromise of the styloid radius. And I perform of the arthroscopy for corneal fusion with a use of the 3 screws and in different positions, and scaphoidectomy with I perform with through to the minimal invasive approach in the volar part of the radiocarpal joint.
I think
this is my option.
So
my
for
opinion
this
is
case, you think? Sorry,
Sorry.
Hannah, you think this deformity do not compromise your approach? You could perform the same way with this big styloid fragment.
Yes.
May I say one word?
Sure,
I think
Professor.
Christophe wants to talk. Christophe, sorry.
It's very interesting cases because you see that there is a scapholinate tears. The patient created by himself a very incredible osteophytes, and now the symptom is just because he broke the styloid. He broke the osteophytes. So
how can we? Sorry, Professor Matulin. How can we see that is an osteophytes than a non-union of the styloid fracture for our young colleagues? How can we see on the
because it's a whole scapholinate, and the patient created osteophytes. You have an X-ray on the other side because it will be interesting to see. For me, the first option will be to remove. I think it will be complicated, but arthroscopically, but we can do it. But the broken distal part of the styloid to check the rest of the styloid and probably styloidectomy. And the problem is if you remove the osteophytes is what's happened in the mid-carpal joint. But I think Ita Ramirez wrote that the very important point is to stabilize and to correct the position of the lunate. It's true. It's true. So for me, I do in one step to remove the broken osteophytes, probably styloidectomy and nothing more in the first time, and we'll see.
Gustavo, where is the pain? Where is mainly the pain? On the radial compartment of the wrist?
Radial side, mostly. It's a very typical pain of a slack wrist. So you could move to the next, Alan?
Yes.
So what I decided in this case, I bring to discussion is that beyond I'm a very enthusiast of arthroscopy. In this case, I predict I would have to struggle so much arthroscopically to perform all the resections. So I would have to use associated mini approach in a similar way. We just see in the beautiful case of the PCR in the beginning of the section. So for predicting that I will need mini open approach for this case, I decided to move directly to a total mini open approach instead of arthroscopic. And since I am using this mini approach, I decided to perform an old technique me and Christophe published together, and we call this the M&M's technique, the Mantovani and Matulin technique, because it's interesting of use of the circular plate using a minimally invasive approach in a double mini incisions and performing a very stable and rigid fixation in order to promote fast and a quick rehabilitation for the patient. So I bring this case for the discussion, and I'm happy that Christophe is here to comment about that. To still have a place for some cases, we have to consider to do our old fashion, open technique sometimes. What do you think, Christoph?
I think I forgot the technique. You know, it's fantastic. No, it's good. It's very good. It's very good. It's very interesting. I remember when we presented this case a long time ago. It was at the beginning of our meeting together, and we call that the M&M's technique. You remember, with beautiful girl during the Brazilian Congress distributing M&Ms to everyone. It was fantastic. No, it's a great idea. It's a great idea. I think it's a very great idea.
I have a question, please, Gustavo, Christophe, everyone. I have the question, like Dr. Jorquera, in this case, why not to do a mini open palmar approach to remove the scaphoid, and after trying to do the arthroscopic carpal fusion? Because of the deformity on the radial side of the osteophyte?
Yeah, first of all, because of I believe that in the volar, I used to make, before the arthroscopic approach, I used to make this M&M technique with a volar small incision for the scaphoid incision. And I still use this volar mini incision to perform the arthroscopic four-corner fusion, because it takes too long to make all the incision arthroscopically of the scaphoid. It's easier. Just like we see in the case of the PCR, it's better to combine mini approach and arthroscopic in order to gain time. But in this case, I was afraid I will struggle too much by volar to remove all the styloid and the attachments on the styloid. So I choose a radial approach for this, so I can have the better access to the styloid fragment and the scaphoid. And then I was missing so much to do the M&M's technique, Christophe, that I choose to move to the plate, and I use the mini approach in the ulnar side of the wrist. That is very easy to expose all the four corner. If I have, in this case, any doubt about the viability of the mid-carpal joint, I think the arthroscopy would be a necessary tool. But in this case, I was pretty convinced that was not doubt, and I will definitely move to the four corner. That's why I decided for this technique.
Thank you so much, Gustavo.
Gustavo, one more word. Could you send me the case?
Of course.
By
I published this case in my Instagram account, and I published this case in some of our.
I would like a PowerPoint, please, because
I will send.
I'm going to use it. It's very good.
Yeah, sure.
Sorry, Christophe, you want someone?
No problem.
Okay,
I take this moment to say goodbye to all of you, my dear friends, because I have
Thank you
an
so much,
appointment in
Gustavo.
5 minutes. I appreciate your effort to put this case online, and I promise to send you.
Thank you for your participation.
Couple of days before the next time, okay?
See you next month, we hope. Bye-bye.
See you guys. Nice to see you all.
So now we will finish with the case from Chile. Please,
yes.
Dr. Javier Sanchez, are you with us?
Hello, yes, I'm here.
Could you share your screen, please, for the last case of the day?
Okay, hello, everybody.
Hello.
Hello, I'm Javier Sanchez Abad. I'm from Argentina. I'm doing my fellowship in the Clínica Indisa in Santiago, Chile. I will present a clinical case about trapezial metacarpal osteoarthritis. And we choose this topic because we want to present our experiences and preference about this pathology. And then we could discuss if you are agree with that or what do you do in this pathology. Fear, that's all. We present a 61-year-old patient with a pain in the base of her thumb. She complains with pinch and grip activities, and radiographs show trapezius metacarpal osteoarthritis stage ETON 3 or 4. She performed rehabilitation exercise for 6 months without response, so we decide to continue with our therapeutic algorithm. We say to perform arthroscopy treatment based in some studies like these 2 systematic reviews, where in the paper analyzed results shown an improvement in clinical outcomes like BAS or DASH, and conclusions recommend arthroscopic assist technique as a safe surgical procedure with good results. Also, with arthroscopy techniques, the stabilizers are not damaged, allowing for faster recovery with less pain. Then we propose to differentiate 2 possible instances for an occurrence diagnosis. We perform a mid-carpal arthroscopy with a MCR portal. We want to see the STT joint to determine if there is an osteoarthritic process of the STT joint or not. If not, we make a hemitrapezectomy with an arthroscopy assist technique, but if the STT joint has developed osteoarthritis, then the trapezectomy is performed. In our case, through a MCR portal, we can see the status of the STT joint. Here, there aren't any degenerative change, and the STT joint could be preserved. So we decide to perform a hemitrapezectomy with arthroscopy assist technique. This was evaluated and presented in the RIGMA journal, where our team published the experience with arthroscopy hemitrapezectomy for the first carpometacarpal osteoarthritis. And here we propose the accuracy of the arthroscopy in the staging of the STT joint. In our case, due to the presence of the ETON 3 trapezius metacarpal osteoarthritis, then we decided to perform a hemitrapezectomy with the 2 standard portals, radial and ulnar, to the first extensor compartment. And with the burr, we resect half of the trapezium, and then we check the height of the trapezium with radioscopy. Once the trapezectomy was done, the hemitrapezectomy was done, we decided to perform a suture button suspension plasty, and a lot of surgical procedures have been
كمية الإزعاج اللي شفناها اليوم تخوف.
Historically, trapezectomy was done with keywords used to maintain the height of the trapezium and allow for the formation of an hematoma. And several authors propose a technique with ligament reconstruction, tendon interposition, only ligament reconstruction, tendon transfer for correction of the hyperextension, and even prosthesis procedures. But in accordance with other authors, we prefer to make an arthroscopy hemitrapezectomy and then perform a suture button suspension plasty, because it allows for early recovery and mobility without the need to use other tissues. In our reported case series, we shown the improvement in BAS and DASH score with good mobility and an average Kaplan-G of 9. Finally, in our case, at the 3 months, the patient has good evolution with a complete range of motion, as we show in the photograph, with a VAS of 2 and a satisfaction of 9 to 10. She come back to the work about 2 months after the surgery. So to take home message, we think that trapezius metacarpal osteoarthritis is a frequent pathology in elderly. Diagnosis is best reached with arthroscopy because it allows for a direct visualization of the STT joint. Arthroscopy assist technique is a safe procedure, and suture button suspension plasty in our hands has good clinical result and allow for early mobility.
Thank you so much for this great presentation. Is there any question in the assistant about the technique, the about the technique, the case? I can see we have.
I think it's interesting to discuss everything thinks that arthroscopy is a better way to assess the STT joint and to perform the trapezectomy or the hemitrapezectomy, or if you perform other kind of surgery like tendon interposition or ligament interposition and tendon transfer. I don't know, what do you prefer? Because in the bibliography, the results with all techniques are similar. So what do you prefer to perform?
Actually, thank you for your case. Actually, I perform arthroscopic hemitrapeziectomy, but I perform also a tendon interposition with the palmaris longus. And my question, that is the option I'm happy with. And as you said, there in the literature, as far as I know, there is no the level of evidence is quite low about which technique to add to the arthroscopy. My question for the suspension with the mini titro, do you have any issues with the mini titro, the hardware, in your experience?
In the clinical case that in the series were published, and in the case that I see, because I don't have a lot of experience in this, I think it's very interesting that first of all, is a minimum invasive techniques that doesn't compress doesn't damage the stabilizer, the ligaments and tendons, and in second place, the recovery, the early recovery after suspension plasty is better than the use of a keyword of a cast that you must to stay with it about 4 or 6 weeks. With this suspension plasty, about 2 weeks after surgery, the patient is starting with rehabilitation and mobility, and in the long term, the results are similar, but in the short term, the results are better because the mobility is better, obviously.
Okay, thank you. And do you think the biomechanical effect on the suspension, after how long do we have this biomechanical effect? After 3 months? 2 months, Dr. Jorge, maybe?
Yes.
Because
yes,
sometimes when we put only pins, as it was already described to suspend, as it was described by Michel Levadou, when we remove the pins, the suspension effect still is effective after 3 months.
We have the 4 points that's very important of defining in this technique. Well, when I put the mini tie rope is in the initial cases I put oblique in position, and currently I put in transversally of the first and the second metacarpal bone in the bases. Okay, it's the first, and when you perform of the drilling for the put on the mini tie rope, I think that the drilling of this zone produce a effect in retract of the union for the first and the second metacarpal bones, and this situation support of the abode of the subsidence, support of the mini tie ropes, retract of the unions of the first and second, and when you resect of the trapezial bone, you resect of mid part of the trapezium bone. Okay, this is very important. The effect in the hematoma in the zone, the third option of the abode of the subsidence.
Thank you for your tips. I have for Santiago team, I have a question from Shunze. what are the tricks to ensure that the burying of the trapeziectomy is effective during the surgery? And what would you do if there is also STT arthritis? So I think you already answered this question during the presentation. Could you repeat, please? We can hear you. Can you? Okay.
Okay. The first question is, what are you trick to ensure the burying and the trapeziectomy? Yes, I use the wet and dry arthroscopy. Yes, and is the arthroscopy of the hemitrapeziectomy is faster, and I use the water for burying. Yeah, extract to the bury and use the dry arthroscopy and resection for the around of the border of the trapezium, and mix it and the wet and dry arthroscopy. I name it of the hybrid arthroscopy. Hybrid is the wet and dry. It's the first answer. And the second, what do you do if the and the second one,
if there is also STT arthritis, the Breitband interposition.
Total trapezium resection. Okay, trapeziectomy. This is I change. What is the condition is in our previous experience, we saw the fields in those who continue with this STT pain in this zone when I perform, for example, on the hemitrapeziectomy and pain in this zone. I see in the second look. I see of the compromise of this STT joint. Okay, and this is in the presentation of the Javier Sanchez. I show what is the experience on the when previous of the hemitrapeziectomy. I saw of the compromise or non compromise of the STT is very important. Yeah, I think that in the classification on the Badia classification of the compromise of the CMC joint compromise 1, 2, 3. I think that the four step of in this classification is very important and define of the what is the compromise of the STT.
Thank you for your conclusional comments. I think we will end the meeting for today. So I hope everyone enjoyed this first meeting. Thank you so much for preparing all your cases, for participating, everyone from everywhere. So next appointment is in about 1 month. For the next meeting, it will be during the IRCAD course. It will be the seasonal forum, and the next IWC meeting, clinical cases, will be scheduled normally at the end of March. So thank you again, and have a nice day, afternoon or evening.
Thank you, Alam. That was a fantastic initiative.
We were very happy to have you today. Maybe next time it will be a webinar and not a meeting, because we had some troubles with the microphones. So we will keep you posted for the next meeting. Thank you, everyone. Bye-bye.
Bye-bye.
Bye. Bye.
Thank you. Ciao.
Bye.